This lecture will summarize the pathomechanism and the pathophysiology of the coagulation disorders. What is the definition of hemostasis? Hemostasis mainly is going to maintain the integrity of the circulation. Basically, it will cause a plaque formation when we do have a rupture of the vessels, and of course, if the plaque should be dissolved. So the vessel integration and the fluidity of the blood is very important. If you do have a problem with the coagulation, if you do have a lower coagulation capability that is called a hypocoagulation, that causes excessive bleeding that can be inherited or acquired one. This is called hemophilias. If you do have, however, an excess coagulation, that is called a hypercoagulation, it will cause thrombosis. This will make an inadequate activation of, or it could be due to the inadequate activation of the fibrinolytic system, and this also caused thrombophilias. Now, which system involves in the hemostasis? First of all, of course, the vascular system. The vascular system, when it's injured, it will initiate vasoconstriction. So it's going to decrease the flow of the blood. Another thing is important, the platelet system. The platelet will adhere to the injured vessels, that the injured vessels, when the collagen is uprooted, and the platelet is going to adhere to these collagen areas, and further platelet aggregation will happen, and that is going to have to form a plaque. In some small injury, that would be clot, would be stop the bleeding out of the small injuries by only having enough platelet in the system. Another thing, the coagulation system that mainly works with a cascade manner. We do have in the blood certain coagulation factors that is going to produce a fibrin polymer, a fibrin plaque. Now these three systems in orchestra, it will maintain the normal hemostasis. Now as you see here in this graph, when the vessels injured, the collagen exposure occurs. This will adhere platelets. The platelets activation, first of all, it's causing the shape change of the platelets. It will cause degranulation of the platelets. That this activation and degranulation, first of all, it will increase the surface area of the platelets, releasing substances that can cause further aggregation of the platelet, but not only this, but is going to promote, for example, or more advanced vasoconstriction will happen. Also, this platelet activation, it will serve as a surface for the coagulation cascade. Now, the vessel injury directly is releasing some tissue factors, and this tissue factor activation will turn on the coagulation, making the thrombinase complex and making the fibrin polymer. The vasoconstriction that directly happening after injury, that of course is stimulated by some platelet-driven agents such as I mentioned, for example, serotonin or thromboxane, and that will decrease the blood flow in this area. Now, this is when we do have only the platelet plug and vasoconstriction. This means there's a primary hemostatic plug. And if we do have a larger wound or a larger injury, we do have a stable hemostatic plug develop. But of course, these two things, the platelet aggregation and the coagulation cascade, will cause a further stop, or that's in uncoercited manner, that will maintain the normal plugging of the injured vessels. Now, the hemostasis usually can be named or can be distributed into three different parts. We are talking about the primary hemostasis that involves the platelet plaque formation, that is going to depend on the number and the function of the platelet, and it will initiate the clot formation. The secondary, the next step, usually it will turn on when we do have a larger wound. This is the secondary hemostasis, when the clotting cascade is activated and the deposition and the stabilization of the fibrin formation, a fibrin polymer formation is happening. This will depend on the amount of coagulation factors and further some anticoagulation properties plus the fibrinolytic cascade as well. Let's see the tertiary. Now we do have the plaque formation, and this plaque should be dissolved to restore the normal circulation, and this involves the fibrinolytic cascade, so dissolving the fibrin clot. This will depend on the plasminogen activation. The primary hemostasis that involves the vasoconstriction, this is a vascular system, the platelet exposure to the subendothelial connective tissues of the blood vessels, the platelet release out of the ADP, thromboxane, serotonin is another component that promotes further vasoconstriction, plus it will promote further platelet aggregation, and the shape change that's happening by the platelet activation that's serving a phospholipid layer for the fibrin formation for the thrombinase complex. Now let's look at the ultrastructure of the platelets. Outside we do have, this is called the glycocalyx. In this peripheral zone, this zone is important in the adhesion and the aggregation. This glycocalyx and the plasma membrane contains several glycoprotein receptors that they do have different properties, such as, for example, the glycoprotein 1b and 9,5 receptors is going to bind the von Willebrand factor. The glycoprotein 1a, 2a receptors is going to adhere the collagen. Glycoprotein 6, again, is another collagen receptor. And another important one, the glycoprotein 2b and 3a receptor, that's the fibrinogen receptors. Now, if we are going a little bit inside the cells, we do have the Sol-Jane zone. This is going to give a structure and support the platelet. This contains some microfilaments and thrombestin and open canalicular system and dense tubular system. And inside the Sol-Jane, we do have the organ zone. This is going to have some granules, and that's important in the secretion and the storage. These granules can be alpha or dense glycogen, or mitochondriums and lysosomes. So this slide summarizes on the glycocalyx the different type of receptors. If you want to go further and you want to know more information about it, you can go to this link. Let's see how this platelet is working in the primary hemostasis.
Platelet adhesion and aggregation. In flowing blood, red cells predominate in the axial stream, while the biconvex disc-shaped platelets are marginated along the vessel wall, where they are well positioned to monitor the integrity of the endothelium. The normal endothelium provides a non-adhesive surface to circulating platelets. However, when vessel wall injury occurs, for example by cutting or severing of a vessel, or as shown here by a puncture, and there is endothelial damage, the initial response of platelets is that of adhesion to collagen fibers in the exposed subendothelium. Collagen is one of the most thrombogenic components of the subendothelial matrix, responsible for the initiation of platelet adhesion. A number of adhesive receptors on the platelet surface membrane interact either directly or indirectly with collagen. Initial binding of platelets is considered to occur via the integrin alpha-2 beta-1 GP1A2A receptor, which allows for further binding to collagen via the GP6 receptor, initiating transmembrane and, subsequently, intracellular signaling. Adhesion of platelets to the exposed subendothelium is influenced by shear rates. At high shear, alpha-2 beta-1 and GP6 are not sufficient to initiate binding to collagen, and binding of the GP1b95 receptor to von Willebrand factor, abbreviated here as VWF, that is immobilized on collagen, becomes essential in platelet adhesion. Platelet adhesion at the site of vessel wall damage initiates activation events that result in aggregation. Adherent platelets undergo a dramatic shape change to an irregular sphere with multiple filipodia spreading on the subendothelium, increasing their area of surface contact. Adherent platelets also secrete or release the contents of their storage granules, the alpha, and dense granules by an exocytic process. This provides a high local concentration of effector molecules essential for platelet plug formation at the site of vascular injury. For example, the aggregating agent ADP is released from the dense granules. Platelet activation stimulates the formation of another aggregating agent, thromboxane A2, abbreviated here as TXA2, via the arachidonic acid cascade. Details are shown in Figure 26.5. The most potent platelet aggregating agent, thrombin, shown here as factor 2A, is formed via the coagulation pathway from prothrombin, or factor 2, on the procoagulant surface of the activated platelet. Details are shown in Figure 26.6. ADP, thromboxane A2, and thrombin bind to specific platelet membrane receptors and stimulate aggregation on and around the platelets adherent to the subendothelium via receptor-mediated signal transduction events. Aggregation is an active metabolic process. Binding of any of the agonists to their respective membrane receptors initiates signaling pathways that ultimately convert integrin alpha-2b beta-3 or GP2b3A from a low-affinity resting state to a high-affinity activated state for binding extracellular soluble ligands such as plasma fibrinogen and von Willebrand factor. Fibrinogen is shown here. The transmission of an intracellular signal leads to disruption of the complex between the cytoplasmic tails of alpha-2b beta-3, followed by a conformational change in its extracellular globular head domains from a bent to an extended state, promoting the binding to fibrinogen and von Willebrand factor. Divalent fibrinogen and multivalent von Willebrand factor function as bridges between alpha-2b beta-3 receptors on adjacent activated platelets, thus allowing platelet aggregation to proceed. In this way, the large and complex metabolic repertoire of platelets allows them to effectively perform their primary physiological role, that of supporting hemostasis upon tissue trauma to form a platelet plug that arrests blood loss from a vascular injury.
Okay, so that was the primary hemostatic processes, as now the secondary hemostasis is turned on. There are several types of this secondary hemostasis. However, this doesn't work in vivo this way. This is the old traditional way what they discovered in vitro studies. So there are, for example, intrinsic pathways, extrinsic pathways, and the common pathways. Now, intrinsic pathways, that's all components required for initiating these pathways, are circulating in the blood and triggered by the contact of the collagen or glass that will activate the intrinsic pathways. The extrinsic pathways, as you learn, that's initiated by the release of the tissue thromboplastin and calcium from the damaged tissue. And of course, these two pathways, the intrinsic and extrinsic pathway, is merging in the common pathways when both forming the thrombinase complex, and this thrombinase complex is going to initiate the clot formation by the conversion of the fibrinogen to fibrin.
At the site of vessel injury, the first platelets arrive to start sealing the wound. Simultaneously, the coagulation cascade with its various coagulation factors is activated. This involves two pathways, the extrinsic and the intrinsic pathway. Extrinsic activation begins with now exposed molecules of the vessel wall, such as tissue factor, which forms a complex with factor 7. Finally leading to the activation of factor 10. This factor 10A is the point at which the extrinsic and the intrinsic pathways of the coagulation cascades meet. The intrinsic pathway consists of various coagulation factors activating each other in a chain reaction. At its end, a complex with an additional cofactor is formed. This complex now activates factor 10. Since the two pathways merge at the level of factor 10A, this factor has a pivotal role in the coagulation cascade. Further down the cascade, factor 10A in combination with 5A activates thrombin and induces the so-called thrombin burst. One molecule of factor 10A can catalyze the formation of 1,000 molecules of thrombin. These large amounts of thrombin cause the further activation of platelets and the enhanced formation of fibrin. Fibrin then forms strands, making up the mesh that stabilizes the platelet plug in an arterial clot and holds together the red blood cells in a venous clot. It can be concluded that the central role of factor 10A in the coagulation cascade makes it a viable target for therapeutic intervention in pathologically altered blood coagulation.
So as you see in the previous movie, in vivo, this coagulation cascade works differently from these extrinsic, intrinsic pathways. They are not separated from each other. So they discovered when relatively they discovered that the patient who has factor 12 deficiency, the patient does not have any coagulation disorders. Usually Hageman disease is associated with the generalized inflammatory reaction because this fibrin of clot, it could not develop surrounding the inflamed site. Now what's happening in vivo? In vivo, when the tissue is injured, the tissue factor is liberated and it will activate factor 7. And factor 7 together with factor 10 and 9, it will form and orchestrated with factor 5, it will promote or will cause some thrombin liberation. Now this thrombin, this small amount of thrombin that is released, it will activate the cascade of this called intrinsic pathways and forming more, for example, factor 11, factor 8, factor 5, and relatively now we do have a most robust thrombin release. This is what you saw in the movies. Now, this thrombin that produced by the thrombinase complex, it will convert the fibrinogen to a fibrin polymer. Now, this fibrin polymer or fibrin fibers is not stable. We have to have some cross-link to make it more stable. And this is the factor 13, or this called Lucky-Lauren factor, that making the stable clot formation. Now, this is another summary of this coagulation cascade, and this is in vitro, and you do see the different part of this cascade that we do have different measurement to take. We are going to measure the intrinsic pathways, let's say component of the intrinsic pathways, by using the APTT. We do have as an extrinsic one that is called the PT time or prothrombin time. And we do have the merge pathways or the common pathways that This is measured as a thrombin time, or together with the activated partial thromboplastin time and the prothrombin time together. Now, this table summarizes the different plasma coagulation factors. And as you see in a different coded manner, the blue one that usually meaning that the concentration increased, for example, by inflammation, pregnancy, or contraceptive pills, and the yellow one represents the vitamin K dependent factors. Now, if you go through, you see that factor 2, 7, 9, 10s are the vitamin K dependent factors. And as inflammation, fibrinogen level will increase, or procalcitonin level will increase, and factor 8 level will increase, and not only during inflammation, but during pregnancy. This is why a pregnant woman usually has a more chance to develop clot formation. Now, this you can look at and what are the different functions of this coagulation factor, such as, for example, the prothrombin, that's a serine proteases, why another factor, for example, the cofactor, for example, the factor 3, the tissue factor, the thromboplastin, or there are several serine proteases that, for example, the factor 7, factor 9, factor 10, factor 11, factor 12, and some transglutaminase, for example, as a Lucky Loran factor or factor 13, and some other is a cofactor, for example, the heavy molecular weight kininogen, for example. That's basically it can be active without having any kind of proteolytic cleavage as well. The fibrinolytic system, the role of the fibrinolytic system, this is a tertiary hemostatic processes to dissolve the clot. So the temporarily fibrin clot systemically and gradually should be dissolved and start the vessel healing. The key components of this cascade is the plasminogen itself. It has an inactive form and several plasminogen activator that is going to activate the plasminogen or plasmin itself. Fibrin, it's a fibrin degradation product that made up by the plasmin cleaved fibrin or D-dimer, we are going to get to later on it, or several inhibitors that usually inhibits the plasminogen activators and plasmin. Now, what's going to regulate the hemostatic processes? There are some naturally occurring anticoagulants that rapidly interact with the component of coagulation cascade, and this will avoid the unwanted clot formation, such as the protein C, for example, and protein S. I will note here these both components, vitamin K dependent as well. Its deficiency can be congenital or can be acquired one. Or antithrombin 3 and heparin cofactor 2. These are serine protease inhibitors, so this is called SERPs. Now, deficiency of these inhibitors that I list in here, naturally occurring inhibitors, this will cause a risk for thrombosis and will develop thrombophilias. Now, let's see the regulation of the fibrinolysis. The major component of the fibrinolysis is the conversion of the plasminogen to plasmin. There are some activators of this conversion, such as the intrinsic activator, that, for example, factor 12 or Hagemann factor itself, the activated forms, or kallikrein, and the extrinsic activation that happening, for example, by bacterial infections, some urokinase like A, or tissue plasminogen activator that will cleave the plasminogen and activate it to plasmin. And the plasmin further, for example, it's going to cleave the fibrin and making some fibrin degradation product and call this FDP. Now, fibrin degradation product is everything. When we cut the fibrin polymers longitudinally, but the cross-link as well. Now, the cleaved cross-link, this is called the D-dimer. Now, there are some other bacteria, for example, toxins such as a streptokinase directly can affect the plasminogen and can convert the plasminogen to plasmin. Now, the plasmin substrate that the plasmin can cleave, there are, for example, the fibrinogen or fibrin and factors 5 or factor 8, so that will deactivate the further clot formation. Now, the next one, we will talk about the bleeding disorders, and we start with the vascular and platelet-related diseases. Let's start to discuss the hemostatic disorders, but the vascular disorders. And after we go to the platelet disorders and coagulation disorders, and we're mentioning some mixed consumptive coagulation disorders. Now, in the vascular disorders, that's a scurvy, easy bruising, or henoch purpura. And the platelet disorders involve some quantitative disorders when we do have less platelet or thrombocytopenia, and the qualitative, that the platelet function disorders such as a Glanzmann disease, von Willebrand disease, Bernard-Soulier disease. In a coagulation disorders, we're mentioning some congenital problem in called hemophilias, such as the A, B, or C hemophilias, and we have to mention the von Willebrand disease here as well, or some acquired problem that due to the vitamin K deficiency and liver diseases. The bleeding features clinically. It's very important as a clinician to look at how the bleeding occurs and evaluate when and how the bleeding occurs. First of all, let's make a difference between the local bleeding tendency and the general bleeding tendency, or whether it occurs spontaneously or whether it occurs after, for example, an injury. Another thing it's important, for example, where and how deeply this bleeding happening. If we do have hematomas or joint bleeding, usually meaning that the patient suffering of some kind of coagulopathy or secondary homeostatic problem. If it occurs on the surface, on the skin, or mucosal bleeding, that usually associated with the platelet or vasculature problem. Or if we do have a wound, large wound, or surgical bleeding, that mostly is associated with coagulopathies or platelet abnormalities. If the bleeding occurs right away, usually that's early bleeding or immediate bleeding that's due to the platelet or vasculature, and when it's occurred later on, that's that delayed bleeding, that's usually as a coagulopathy, sign of the coagulopathy. Now, on the picture, if we're looking at, for example, it's starting from the petechias or goes to all the way to the purpura, that usually meaning the patient has problem with the platelet. In hematomas or joint bleeds, that can caused by coagulopathies. Now, in this table, I summarized the different vascular function-related diseases. Now, that will happen, for example, infection. And here we do have a microvascular injury or vasculitis, and that can be due to different, for example, bacteria or toxins. Or can be some injury or varying problems, and it can be due to the connective tissue atrophy or connective tissue formation abnormalities, and that can be due to the purpura senilis or can cause the purpura senilis. The medication can cause a vascular bleeding problem, such as when we do have a drug deposition making an immune complex, and the inflammation can cause a permeability of the vessels. Certain drugs, allopurin or cephanol, there's a cephalosporin, the second line cephalosporin, or colony-stimulating factor, furosemide, or D-penicillinamine, for example, can cause these problems. Vascular wall weakening that can be due, for example, to collagen damage, such happening in Cushing syndrome or scurvy or Ehlers-Danlos syndrome, and that's an inherited problem. Or altered TGF-beta signaling mechanism, for example, hereditary hemorrhagic telangiectasia or Schler-Weber-Rendu syndromes, for example, that's another is a inherited diseases. Or immune alteration, when we do have the deposition of the circulating IgA, for immune globulin, that's happening in Hemlock-Schönel purpurae. Or amyloidosis, deposition of amyloid, for the light chain amyloidosis that's happening. This all will alter the vascular wall. Henoch-Schönlein purpura is the first one. That's a small vessel vasculitis, usually characterized by some purpura or arthritis and abdominal pain and hematuria. The illness is considered by histopathology to be an IgA-mediated vasculitis of the small vessels, and the etiology of this Henoch-Schönlein purpura is unknown, but it typically follows an upper respiratory tract infection. Almost 50% of the patient has altered anti-streptolysin or titer antibodies implicating a group A streptococci infection. It's more frequent in children than adults. It mostly occurs between the age 2 and 8 years. And the concentration, for example, of the cytokines, such as the interleukin-6 or tumor necrosis factor, it's also increasing in these diseases. In this Schönlein purpura, the IgA nephropathy are related disorders, however, and IgA nephropathy almost exclusively involves young adults and predominantly affects the kidney only. Immunofluorescence techniques may show deposition of IgA and the complement cascade component of the C3 in the small vessels of the skin and renal glomeruli. The next one, when we do have a problem with the platelet, let's start with the decreased production rate. That can be due, for example, due to the decreased megakaryocyte number. That they do have a normal platelet lifespan, however, we do have a less megakaryocytes, so less platelet is formed. And this will respond very nicely to the platelet transfusions. Neoplastic causes when we do have leukemias, hematologic diseases, or metastases, or drug or chemotherapy that suppresses the bone marrow, and this is why less megakaryocytes or the function can be altered as well. Or primary marrow disorders such as a megaloblastic anemia, as a vitamin deficiency, or myelodysplastic syndromes or myeloproliferative syndromes also can cause thrombocytopenia, and there are some other congenital syndromes that influences the platelet count. Now, when we do have not the decreased production, but we do have an increased destruction that also can decrease the platelet count. In this case, the platelet lifespan decreased, and in response to, we do have a more pronounced proliferation of the megakaryocyte to counteract with the decreased platelet count. Of course, in this situation outside, we could have a macroplatelets, that the platelet usually is a few micrometer in diameter. Now they do have more. And in this situation, the platelet transfusion, it doesn't help too much the patient because the newly transfused patient can be used up immediately. Now, what could cause this situation? That can be immune-mediated or can be due to consumption or septicemia. The immune-mediated are marked with red. This is the idiopathic thrombocytopenic purpura, but lymphomas or lupus rheumatoid diseases or drug can induce an immune-mediated decrease of the platelet count. Or consumption, for example, the thrombotic thrombocytopenic purpura or hemolytic uremic syndrome or disseminated intravascular coagulation, this all is going to use up the platelet. Whatever is made in red, we will talk about later on. Now let's start with the idiopathic thrombocytopenic purpura, or the abbreviation is ITP. That's an acute, usually happening after infection in children, and it's more chronic in adult one. Usually it's happening in females one, age between 20 and 40s. This is an IgG mediated process when the IgG bound to the platelets, and that's relatively these platelets that is marked with IgG is cleaved by the macrophages. And autoantibodies can act on the marrow, not only on the platelet as well. And no good diagnostic test is present so far, but the treatment usually what we do have, we can inhibit the macrophage clearance of this platelet by using corticosteroids or high-dose gamma globulins, for example, or we can perform a splenectomy. The next disease is the thrombocytopenic thrombotic purpura. We do have a thrombotic plaque formation in the microcirculation. That this kind of plaque is composed mainly of the aggregated platelets and von Willebrand factor with a small amount of fibrin. This meaning that we do have the presence of the unusual large von Willebrand factor or the UL von Willebrand multimers that anchoring the platelet and a small amount of fibrin. This is the problem when we do have this multimer of the von Willebrand factor due to a decreased activity of the ADAMTS13. Let's look at how does it work.
It's called ADAM-TS13. Platelets coexist with many clotting factors. One is called von Willebrand factor, and it catches the platelets, helping them to clot. Imagine tennis balls caught on strands of flypaper. To keep the platelets from clumping together too much, ADAM-TS13 cuts through the von Willebrand factor and allows the platelets to continue moving. Inhibiting ADAM-TS13 allows dangerous blood clotting throughout the body and causes TTP.
Other one, that's hemolytic uremic syndrome. Now, in this case, in a lesion, in a pathologic lesion, predominantly the fibrin containing thrombus can be found and due to the endothelial damage. The thrombi are largely confined to the renal circulation. Now, the pathomechanism is two types. One, when we do have some kind of toxin, the Shiga toxin-induced glomerular endothelial injury, that is a colitis, for example, O157-H7 related colitis, or it can be idiopathic one that's due to the factor H deficiency that leads to the inappropriate activation of the complement system. Now, another thing that we should mention, that's a heparin-induced thrombocytopenia, or its abbreviation is HIT or HIT. There are two types, major type. The type 1 is a not immune-mediated pathways that usually happening when the heparin binds to the platelet factor 4 receptors on the surface of the platelet, and adhesion and aggregation happens, and this is why the platelet count will decrease. The type 2, that's an immune-mediated and more severe condition when the platelets are cross-linked with the Fc receptor with an anti-platelet factor 4 heparin complex antibody that again causes adhesion, aggregation, and the number of the thrombocytes will decrease and thrombosis will happen. The important to note here that the unfractionized heparin that they used to use causes more frequently HIT, about 10 times more than a fractionized or the low molecular weight heparin. And this kind of HIT is more common one, the immune-mediated more common one in women. Another problem with the platelet function defects such as an adhesion problem, that's a Bernard-Soulier disease, when the glycoprotein 1b9 complex is missing on the surface of the platelet, and this is glycoprotein, that's the receptor for the von Willebrand factor. Only adhesion mediators and high stress be altered. And attested by the ability to aggregate platelets is the presence of ristocetin, that the antibiotic that usually activates the platelet through this von Willebrand receptor. Another one is called the von Willebrand disease, and this meaning that we do have none unless von Willebrand factor, and this is causing the platelet adhesion problem. Now let's look at this von Willebrand disease. This von Willebrand disease is a combined disease because it will alter the coagulation, plus it will cause a platelet disorders as well. That's congenital disorders. Usually the molecules of the von Willebrand factor molecules is missing, or it's an abnormal structure that it has. And it's this von Willebrand factor that mediates adhesion. And this is why we do have a prolonged bleeding time. Plus, because von Willebrand factor is part of factor 8, and von Willebrand factor stabilizes factor 8 in the circulation, now in the absence of Willebrand factor, we do have a low factor 8 level. This is why the activated partial thromboplastin time that measures the intrinsic pathway is elongated. And this manifested as a surface bleeding, some mucocutaneous bleeding, and deep bleeding as well due to the platelet disorders and the coagulation abnormality. Now, the different types of the von Willebrand diseases, as you see here, there are some that is a quantitative deficiency, such as type 1 and type 3. Most common one is type 1. When we do have a partial quantitative deficiency of von Willebrand factor, that's an autosomally dominantly transmitted diseases. Type 3, but virtually we have no von Willebrand factor in the system, and that's a recessively hereditary diseases. The other type, that's type 2A, B, M, and a lot of type when we do have a qualitative deficiency of the von Willebrand factor. That the qualitative variant, for example, 2A, with a decreased platelet-dependent function associated with the absence of the high and intermediate molecular weight von Willebrand multimer. Or we can have the B type, that the variant with increased affinity, for example, for the platelet glycoprotein receptor, the glycoprotein 1B receptors. Or the 2M, for example, the variant when we have a decreased platelet dependent function not caused by the absence of high molecular weight multimer. And some other one, that quantitative variant with a marked decrease in affinity for the factor 8. The differentiation is happening when we do have an electrophoretic differentiation of these different types of von Willebrand factors. However, you should remember very common one, the type 1. Now, how do we treat this von Willebrand disease, especially type 1? You'll be surprised, we are using desmopressin or vasopressin, and that's a vasopressin analog that through the vasopressin 2 receptor, it will stimulate the production of and release of the factor 8 and von Willebrand factor. In those people who need some prophylaxis, this intranasally use desmopressin is enough. However, if they need some kind of operation in preoperative prophylactic use, they are using as an IV. The platelet function defect, when we do have an aggregation abnormalities, that's a congenital disorder that's called the Glanzmann's thrombasthenia or Glanzmann diseases. That's an autosomal recessive diseases when we do not have the fibrinogen receptor on the surface of the platelet. The platelet cannot aggregate in response of usual stimuli, and bleeding sometimes is very severe one. Another things when we do have a secretory defects, and that is called the storage pool diseases. The lack of the granules formation in the megakaryocytes in the functional defective granule production can happen. That is listed such as a delta storage pool diseases or alpha delta storage pool diseases or alpha storage pool diseases that altering the function of the platelets. Usually the further aggregation is diminished or inhibited. There are some acquired disorders of the platelet, such as a drug-induced abnormality of platelet function. That can be due to, for example, the alcohol that affecting the platelet directly or can affect the megakaryocytes, or it's very commonly, for example, by some inhibitors of the prostaglandin synthase, such as aspirin or NSAIDs and phenibutazone, for example, or when they're using some ADP receptor inhibitors, such as the ticlopidine or clopidogrel, for example, or some antibiotics, the beta-lactam antibiotics, or heparin itself can induce some platelet function defect. In the next series of this some slide, we're going to talk about the coagulopathies and consumptive coagulopathies. So now this is the secondary homeostatic processes is involved. Now the coagulation disorders, usually we do have a problem with the coagulation factors or the amount of the coagulation factor mostly. How is manifested? Usually after the trauma we do have a delayed bleeding tendency, and we do have the deep bleeding. Usually the bleeding occurs into the joints. This is what is called hemarthrosis, or into the deep tissues. Hematomas can develop, or large screen bleeding can happen. This is called the ecchymosis. Now, disorders, what can be the laboratory findings of these coagulation disorders? Very importantly, the bleeding time and the platelet count is not influenced. Now, as we learn in physiology, bleeding from a small cut usually is stopped only by activating the vascular vasospasm and the platelet adhesion aggregation, so the primary plaque formation will stop the bleeding from the small cut. And when we measure the bleeding time, as you can see in the practical note, that we are making a small cut, very sharp cut, when the edges of the vessels, the cutted vessels, are very close to each other, so that's platelet and vascular problem. The prolonged prothrombin time, that usually meaning that we do have a problem with an extrinsic pathway, the deficiency of factor 2, 5, 7, and 10. If we do have a prolonged time for the activated partial thromboplastin time, usually every factors except the factor 7 and 13 can be seen, because they are different. They are not involved in the common pathways. Now, the mixing studies that they are using, usually this is differentiating the factor deficiency from the autoimmune mediated deficiency. This test usually is set when we do have about 50% of or 20% of presence of the coagulation factors. These times are normal. However, if you do have less than 20%, this is not normal. So if we mix the patient plasma with the normal plasma, we bring up the level of the coagulation factors to at least to 50%. So that should normalize the P time or APT time, unless we do have an anti-antibody, because this autoantibody that reacting against the factor, that will bind to the normal, the coagulation factor present in the normal plasma as well. Now, let's talk about hemophilias. Hemophilias is a congenitally hereditary disorders, most commonly hemophilia A, that's a factor 8 deficiency, hemophilia B, that's a factor 9 deficiency, and hemophilia C, that's a factor 11 deficiency. We can have some problem with the secondary hemostatic disorders that induce, for example, vitamin K deficiency. Now, in neonates, usually they do have a very low level of vitamin K, because the intestinal flora usually develops after delivery, sucking the bacteria from mother and drinking milk. That is going to build up the normal flora of the baby. But it can develop due to, for example, some drug treatments such as a coumarin that is going to inhibit the reactivation of the vitamin K cycle, or if we do have a fat malabsorption, that can be due to, for example, with a bile duct obstruction, or when we do have an abnormal release of the lipase from the pancreas due to the chronic pancreatitis. And another factor that usually it should you remember, that factor 2, 7, 9, and 10, these factors are depending on vitamin K, because they need to be gamma carboxylated to forming a thrombinase complex on the surface of the platelet. So this is why if you measure the prothrombin time or APTT, both elongated, mostly the prothrombin time is elongated. This is why the vitamin K treatment should be checked by measuring the prothrombin time. Now, the combined primary and secondary hemostatic disorder, that is what is called the disseminated intravascular coagulation, or DIC. There's the major pathological process that can happen, for example, an obstructive complication in the patient has neoplasm tumor or infection, most commonly sepsis or major trauma, that induces the activation of the platelet aggregation, adhesion aggregation. So at the beginning, we do have a platelet consumption. So the bleeding time will elongate and the platelet count will decrease. And this kind of adhesion and aggregation happening in systematically. Later on, this platelet aggregation is going to induce the coagulation cascade, the secondary hemostatic processes, and the factors is consumed. So later on, the prothrombin time, the APT time, and thrombin time, it will elongate it because the all factor levels will decrease. Combined hemostatic disorders, such as when the primary and the secondary hemostasis is influenced, can be due to severe liver diseases. So the primary, the platelet function, can be altered due to, for example, the splenomegaly or portal hypertension or the toxic material accumulation when the patient does have a dysfunctional platelets and thrombocytopenia. So mainly the bleeding time is elongated. The liver is very important to synthesize coagulation factors. So if you do have an abnormality of the liver, certain coagulation factor levels will decrease almost every factor except factor 8 and von Willebrand factor because they can produce by some other cells such as the endothelial cells or almost all cells of the body can produce it. So in this case, the secondary hemostatic secondary hemostasis is altered. What kind of therapy can be used? Importantly, vitamin K administration can promote the synthesis of factor 2, 7, 9, and 10. Now the next one, this is the most common abnormality of the hemostasis. This is what is called the thrombophilia, and usually it causes the most severe problem because when we do have a hypercoagulability stage that causing a thrombus formation, and relatively this thrombus happening in the wrong time and the wrong place, and after there is no blood circulation, so relatively those area that is plugged behind the clot formation is completely ischemic and can be necrotized. This is why thrombophilias can cause much bigger problem than hemophilias. Now, what is the pathophysiological differences between the arterial and venous thrombi whenever it's happening? In some happening in the arterial side and some happening in the venous side. What you learned, the arterial side, usually we do have a white thrombi formation, while in the venous side we do have the red thrombi formation because usually we do have much more red blood cells inside this clot. When we do have an arterial one, only majorly we do have only the platelet and the fibrin. Now let's see what these can causes. For example, the vasculature problem. When we do have atherosclerosis or vasculitis or trauma, that usually altering the arterial side when we have a higher shear stress, for example, higher blood pressure, so more damage happening on the arterial side. Thrombus, pathological thrombus formation, and usually occlusively or non-occlusively mural thrombi in a large arteries, and that's, as I mentioned, this is the white thrombus formation, the composed mainly by platelets and fibrin. And in the venous side, this is a red thrombus composed mainly with fibrin and red cells. Pathophysiological one as a local shear stress, as I mentioned, it's increased in the arteriosal side. This is why the thrombogenic vascular surface occurs due to the atherosclerosis or damage of the endothelial layer. Why in venous thrombus formation? Mainly due to the stasis and some other problem that alter the inhibitory, the naturally occurring inhibition of the coagulation cascade. Now, the Virchow triad in thrombosis, meaning that we do have three different participants of this system. If we do have a problem with our endothelial wall, if we do have an endothelial injury, that can promote thrombosis. If we do have an abnormal flow, for example, stasis or turbulence or anything, again that can lead to thrombosis. Or when we do have a hypercoagulability stages, when we do have an alteration of the naturally occurring anticoagulation cascade, that again can cause thrombosis. Of course, these different participants can act each other. If we do have an endothelial injury, that can induce hypercoagulability stages, and of course it will cause abnormal blood flow, but abnormal blood flow can cause endothelial injury as well. So these three participants usually affecting the thrombic formation in an orchestrated manner. Now, the clinical manifestation of the hereditary thrombophilias, usually we do have a family history and with venous thrombosis. And another very important one, the thrombosis usually occurs in early age and in an unusual site, such as, for example, the inferior vena cava or mesenteric vein thrombosis happening in a young person, or cerebral vein thrombosis or renal vein thrombosis happening, and sometimes the axillary vein thrombosis occurs. And these thrombotic events usually recurrently occurring in this patient. And this venous thrombus formation can occur with a minimal provocation immediately. Or heparin resistance can happen. The heparin doesn't work in this patient, that possibly due to the antithrombin 3 deficiency. Or neonatal purpura fulminant can develop due to protein C or protein S deficiency. Because you know that at the beginning when the baby delivered there is no vitamin K, and because protein C, protein S is vitamin K dependent factors, and the other coagulation lifetime of the other coagulation factors are longer one, and this is why from the mother that those coagulation factors is still active, why this anticoagulation cascade is not active. This is why the patient develops a thrombus formation in the vessels, in the skin vessels. Or coumarin necrosis very similarly, and this is why when the coumarin is introduced into the patient, it should be done in a prevention with heparin, because as I mentioned that vitamin K deficiency will decrease the level, first the protein C and protein S, because the lifespan of a coagulation factors is longer than these anticoagulation factors, and this is why first the patient will have an excess thrombus formation. Of course, later on, this won't happen because both inhibited with the same way. So this is why you have to apply heparin that inhibits the coagulation cascade immediately. And after, when the coumarin dose is reaching the therapeutic plateau, after you can stop giving the heparin to this patient. Now, hereditary thrombophilia syndrome can be, as the most common one, that's a factor 5 or the Leiden mutation, protein C deficiency, protein S deficiency, or antithrombin 3 deficiency, and very rare, the prothrombin mutation that giving a change of the glutamine to the alanine about position of 20 to 210, or the methylene tetrahydrofolate reductase mutation, for example, the C677T, that can cause a hereditary thrombophilia. The acquired one is usually due to aging. If you look at the incidence of this hypercoagulability stage below, for example, 40, a young one, maybe 1 out of 10,000 people can happen. However, over 75, 1% of the patient could have a hypercoagulability stage. After major surgery, because the tissue factor liberation again can promote, let's see, the coagulation. This is why the patient usually will get heparin prophylaxis. Myeloproliferative diseases that we will mention later on, again that can promote the coagulation. Or prolonged immobilization by sitting on an airpace or laying in the bed because you are sick. Another very important one, taking oral anticonceptives, that this will increase the risk about 20 to 150 times, especially those who has some kind of Leiden mutation as well. Pregnancy itself can cause a hypercoagulability stages. Or malignancy, active malignancy can promote it, or antiphospholipid syndrome can cause it, or hyperhomocysteinemia. These all can induce hypercoagulability and thrombus formation. Now, why pregnancy is an hypercoagulability stage? First of all, the mother has a venosostasis. Another one, in this mother, we do have usually an elevation of the von Willebrand factor level, factor 8, factor 5, fibrinogen concentration increases, and this patient will have an acquired protein C resistance as well. And during pregnancy, the protein S level decreases, and the fibrinolytic cascades such as the PA1 and PA2, the plasminogen activator inhibitor 1 and 2, it's elevated. This is why there's more chance to coagulate. The antiphospholipid syndrome, or this abbreviation is APS, is relatively common in autoimmune patients. These autoantibodies, however, directed against the phospholipid cell membrane, not exactly against the phospholipid, but the membrane component, and that is what is called this antiphospholipid antibody. The antibody which effective the APT time, the clotting test, this is what we discussed during the practices, that's an anticardiolipin or APA. This is the IgM or IgG molecules, or this is called a lupus anticoagulant as well. Now, these antiphospholipid syndrome can be primary or secondary. The primary, we don't know the cause, and secondary usually associated with some other autoimmune diseases, such as, for example, lupus, systemic lupus erythematosus. And when we do have this anticardiolipin antibody, there's IgE, that is clinically important, and this is what they are checking it. IgM usually occurs during pregnancy, and viral infection, trauma, and post-operation can happen. The multifactorial pathophysiology of thrombosis in cancer patient involves, first of all, the altered blood flow. That can be due to immobilization and bed rest, or vascular compression from a bulky tumor, or hyperviscosity. Another thing, the vessel wall is altered. For example, the direct vascular invasion by the tumor, or reduction of the plasminogen activator within the vascular endothelium. Another one, the abnormalities of the blood composition, elevated the fibrinogen level, factor 5, 7, 8 levels, or decreased clearance of the activated factors because the blood flow is altered, and activation of the coagulation system by the tumor cells itself, especially when they necrotized.